University Health Network Memory Clinic and University of Toronto. She received her medical degree from McGill, completed her residency at the University of Western Ontario, and did 3 years of clinical research fellowship in cognitive and behavioral neurology at the University of California, San Francisco. She maintains a cognitive behavioral clinic within the University Hospital Network where she sees patients with neurodegenerative diseases with a focus on frontotemporal lobar degeneration-related syndromes. As well, she is interested in the delayed effects of concussion and sees patients with post-concussion syndrome, including those with multiple concussions who are at risk of developing neurodegenerative disease. She holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research. Many thanks for joining us today for this Grand Round presentation, and I'll pass it over to you.
Thank you for the invitation. It's my pleasure to be speaking to you today with an area that is actually close to my heart. So I'm going to head right in. These are my disclosures. I have some grants and I do some clinical trials. So really my objective is to go over some of the imaging help that we now know is very useful for making accurate diagnosis when dementia-causing disorders as well as movement disorders, and really going over some of the new criteria. So I don't think I need to tell anybody that our growing population of the older adults is definitely upon us, and we've managed to make a lot of headway in cancer and in heart disease and infection, and so the elderly are actually the fastest growing population, at least in Canada and some of the other societies also. So this is just to highlight that you can see here that the older population are the fastest growing population. Actually, in Canada a few years ago, the people over the age of 65 far outnumbered people under the age of 15. And so, because of this, there's been a real paradigm shift in neurodegenerative diseases. We have new criteria that have come out for many of them. We now understand that, we can't just go around saying dementia. There's, specific distributions of pathology. There's different types of pathologies. As well, we now understand that these pathologies develop years before clinical signs of disease, and that there are ways of investigating them. So just to remind everybody about the dementia criteria, because people often die with a diagnosis of dementia, which would be in a way like dying with a diagnosis of a cough. And dementia basically means you have cognitive behavioral symptoms that interfere with usual work or social activities. It's a decline from previous level of functioning. It's not a delirium. It's not a major psychiatric disorder, and it's a detectable cognitive impairment that we can detect with neuropsych imaging, and it could be inability to learn new information, which is the most common way of people presenting, but it could also be just impaired reasoning, handling of complex tasks. It could be impaired visual spatial processing. It could be impaired language function, and it could be just a change in personality or your usual character. But it's actually not a diagnosis, that is of relevance in terms of understanding what the cause of somebody's problem is. So, it's an umbrella term, and it includes many, many different diseases. So the most common, I guess in our society, the most common diseases we think about are the neurodegenerative diseases like Alzheimer's and, Parkinson's disease, dementia, or Lewy body disease. Of course, there's, cerebrovascular disease, but there are many other non-neurodegenerative causes of dementia, so multiple sclerosis, brain trauma, HIV infection, metabolic disorders, autoimmune disorders, so many different causes of dementia that need to be considered. And the reason that it's important is because when we look in pathological series, we see repeatedly that, there are different causes, and although for many people, Alzheimer's disease and dementia are used interchangeably, they are not the same thing. And so it actually is turning into a big problem now because a lot of patients don't understand that. And so, they come to us and they say, well, I have lots of family members who had Alzheimer's disease, and so I must be at risk because, I forgot where I parked my car. And when you talk to them, you realize that actually some of their family members did not have Alzheimer's disease. Some of them had multiple strokes and probably had cerebrovascular disease, which is actually not that uncommon. Some people had Parkinson's disease. So it is actually important to give people an accurate diagnosis because it does have implications, even if we don't have a cure. And, I think in terms of talking about cures, we're hopefully moving towards, targeted therapies for these proteinopathies. This is the term that we use for neurodegenerative diseases these days. We know these abnormal proteins are clustering in different parts of the brain, in different types of cells, and we think are leading to the neurodegenerative aspect of the disease in terms of the brain shrinkage. And so when you think of targeted therapies, you would you wouldn't want to give an amyloid therapy to somebody who has no amyloid in the brain. You wouldn't give something related to alpha-synuclein to people who don't have alpha-synuclein in the brain. And although this seems preposterous and in cancer would be completely unacceptable, you have to remember that in 2013, there was a huge trial in Alzheimer's disease where it was found out that about 30% of people in the trial who received an anti-amyloid therapy actually had no amyloid in the brain. So that was the last trial where it was acceptable to put people without biomarker-proven Alzheimer's disease in trials for Alzheimer's disease. Today, we do need to have biomarkers. And so, Alzheimer's disease, as well as a number of other illnesses, have actually undergone revised criteria to try to move towards more precision about them. So for Alzheimer's disease, this is cognitive deficits are evident on history, examination, and people think often of the amnestic presentation, and it is the most common. So people with an inability to learn or recall, but we now realize there are so many people with non-amnestic presentation. So they can have a language presentation, a visual spatial presentation, executive dysfunction, or personality changes, and it's important to consider that Alzheimer's disease could be a cause of these for these patients. And of course, in terms of the diagnostic precision, we can get to probable when we have more. We can use biomarkers to show that yes, in fact, there is amyloid in the brain, or there is phosphorylated tau in the brain, and we can look at glucose metabolism. We can, obviously with PET, we can actually detect amyloid and tau, or they have mutation carriers. And that's to try to arrive at a more precise definition of Alzheimer's disease and to really, differentiate between the Alzheimer's disease dementia, what you see, what the patient has, but Alzheimer's disease as the cause of that dementia. So, in Alzheimer's disease, one of the things that we look at are, the structural changes. Now, structural changes in Alzheimer's disease are actually not diagnostic in the sense of, although it is a biomarker of degeneration, we can't use structural imaging to be definitive about the underlying cause. And so when you look at this, coronal view, you can see what we usually expect to see, in a patient with Alzheimer's disease versus mild cognitive impairment versus a normal, 65-year-old patient. And, obviously the 65-year-old patient does not look like a 30-year-old. So there is, some shrinkage of the brain. In this case, we would say age appropriate. You look at the hippocampi, look, quite good. And then you see in mild cognitive impairment, in this case, thought to be due to Alzheimer's disease. You can see that there's some flattening of the hippocampi and obviously some widening of the sulci, enlarged ventricle. Of course, this is, not as bad as what you see on the far right, where you see, significant atrophy of the hippocampi. You see widening of the sulci and lots of ex-vacuole loss also. And so, this is a case of proven Alzheimer's disease, but in the end, this wouldn't be enough to make a definitive diagnosis of Alzheimer's disease. We know that even in the early stages, there is a pattern of atrophy we can look for. And so, it's become the Alzheimer's signature. So to kind of help us, direct our thinking towards, yes, this could be Alzheimer's disease in very early stages. And this includes, the medial temporal lobes, the hippocampi, as well as this precuneus posterior cingulate area. And it's now come to know as the Alzheimer's signature. Some people have taken to measuring the hippocampi, which obviously can be useful. There's, I know, automated measurements now. And so, one could envision that in the future, people could track this. People could use this to see response to therapy or to prognosticate. And, probably this would be tied into some other biomarker like, phosphorylated 181, which can be done in the blood. So we can envision that our area in terms of neurodegenerative disease will be completely transformed in the next few years. And, we are hoping to move towards the precision medicine that, exists in cancer, at least. So in terms of, some aids for the neurologist, people look at this global cortical atrophy scale, and so sometimes report, there's a number of these scales that have been designed to try to help kind of harmonize the reporting. We often get these reports that say, atrophy compatible with age, but that is not very meaningful. And sometimes when we look at it, we say, well, I really would not like to have that brain when I'm 65. And, we all see lots of brains in even older patients that look fantastic. And so, I think it's very difficult. And so there's a few of these scales that were designed to try to kind of harmonize or standardize the reporting so that when somebody says, there is actually global atrophy, it becomes more meaningful. And so this is one of the scales called a global cortical atrophy scale. There's also the Shelton scale of medial temporal lobe atrophy, and I'm not going to belabor, some of you probably know this better than me, but trying to again formalize, standardize the reporting so that there's certain landmarks that people can use to try to be more precise. And although volumetrics is probably the way forward, many of our programs right now are not able to spit out volumes for the medial temporal lobe areas for the hippocampi. And so some groups have moved towards this more standardized reporting of Shelton scale. And this is just to show you what it looks like on a coronal image. And there are certain there's revisions to this, but it was thought, I guess the original scale, if you were less than 75, a 2 would be abnormal, and if above a 2 would be abnormal. If you were above 75, getting 3 or above is abnormal. And again, it's just trying to become more precise in reporting this. This is a posterior parietal atrophy score. As I've alluded to previously, we now know that there's this Alzheimer's signature, and it includes the posterior cingulate parietal region. And so this score has been designed, and some people are using this also. All these scores are very helpful, but they are not diagnostic. As I've mentioned, these scores are really to help maybe help the clinician make a diagnosis without, when they don't have biomarkers available. So we're fortunate, we do have biomarkers for Alzheimer's disease. So we have ways to make an accurate diagnosis, and it's been around for like over 20 years. Unfortunately, in some places, including our place, this is not routine. So we actually, in Ontario, do not have access to cerebrospinal fluid assessments that are covered by our healthcare system. So, we have socialized healthcare, but in Ontario until 2019, they actually used to cover cerebrospinal fluid assessment for Alzheimer's, and then they stopped. We don't have access to PET for biomarkers for Alzheimer's disease. PET here is used mostly for cancer. So we do these under research conditions, but you can see there how, how the accuracy is actually quite high with amyloid imaging, amyloid PET imaging with high sensitivity, high specificity, the same for cerebral spinal fluid. So we really do have the ability in Alzheimer's disease to detect this disease while people are alive. For a long time, people were using PET amyloid, but in the last few years, we have PET ligands for tau, which you may know is tau actually dictates cognitive function. So it's actually the level of tau in the brain that correlates best with our cognitive abilities, our functional abilities. And so there are now very good tau biomarker, tau PET ligands that can be detected even when people are in early stages of disease, very mild stages, as well as in Alzheimer's. There are certain patterns that we look for. We have first generation, which are routinely used in clinical trials, not for clinics, but in clinical trials. There's PET tau imaging. They're used in research. There are also second generation ligands. So this is an evolving field, and we hope will be part of prime time diagnostics in the near future. I think this was a very large study, and I think there was one in Europe too, really showing this was a PET amyloid study done across the United States, 18,000 scans to assess how receiving accurate diagnostics really impacted care. And I think they wanted that they hypothesized that there would be like a 30% effect on whether it was diagnosis, whether it was management. And so, across the US, they did this in many different sites. And basically, the criteria for entering is that you weren't sure. You weren't sure what the patient had. It could be Alzheimer's disease, and it could not be, but the results would have to impact your care. And this was the population. There was, mild cognitive impairment as well as more advanced dementia cases. And this was the first pass at it. So there were around 10,000 patients. And in this, when they did this interim analysis, they showed that in actually 60% of the cases, there was some change, whether it was in diagnosis, whether it was in management. And so that's pretty significant because, there aren't that many things that we do that result in this much change in our practice. And so this really did highlight that being more precise, being able to give people a diagnosis did result in change in practice. I'm going to say just a few words about cerebral amyloid angiopathy. So you probably know that Alzheimer's disease, there's amyloid in the parenchyma of the brain as well as tau, but there's also a disease where amyloid builds up in the blood vessels of the brain. And so this disease can be associated with parenchymal Alzheimer's, so parenchymal amyloid, and so these people can have cerebral amyloid angiopathy as well as Alzheimer's disease, but it could also be that they only have cerebral amyloid angiopathy. And imaging actually is core to the diagnosis. So when you see patients with lots of microhemorrhages in the brain or some lobar hemorrhages, to really consider, and this, you need to do susceptibility weighted imaging or gradient echo imaging to do this. And I know there's some debate because susceptibility weighted imaging actually is more sensitive. And so, picking up a lot more microhemorrhages than gradient echo. So they're difficult to compare. And so there's ongoing debates of which is better. Nowadays with, anti-amyloid therapies actually becoming envisioned as a reality, some people are worried that if you because microhemorrhages are actually a exclusion criteria, that if you get susceptibility weighted imaging, you might actually exclude a lot more people. So this is, this is a work in progress, let's say. So now I'm going to move to Lewy body dementia as well as Parkinson's disease dementia. So these illnesses are, in the alpha-synuclein spectrum. And so both of them are caused by Lewy bodies, but in different parts of the brain. So Lewy body dementia is when we see, dementia early on, some fluctuation of cognition, visual hallucinations. Parkinsonism, these people usually have, REM behavior disorder. They'll have severe neuroleptic sensitivity. And, Parkinson's disease is actually kind of the opposite side of the coin, where patients will have classic Parkinson's disease of tremor, slowness, rigidity, and then they develop dementia. Now, new criteria came out for Lewy body disease a few years ago, and this was really to highlight the importance of this REM behavior, because as I mentioned, we now know that all these neurodegenerative diseases actually start years, decades, actually 20 to 30 years before you see any signs of disease. And so it becomes very important for us to think about, how are we going to detect early on? When you think about the fact that 80% of your substantia nigra cells are gone when you detect Parkinson's disease, you've got to think, like, the horse is out of the barn by then, and how are we going to bring those cells back? So I think the fields are all moving towards trying to find earlier and earlier biomarkers, whether they're clinical, whether they're, biofluid or imaging, to try to detect people at the earlier stages. In terms of imaging assistance with Lewy body disease, some people are using SPECT scan. This is, again, not diagnostic per se, but can help in the diagnosis. And so the classic is to see, occipital hypometabolism on SPECT imaging. DAT scans, which is a photon emission computed tomography for detecting dopamine transporters, are often used. And you see on the left what a normal basal ganglia can look like, and then you see on the right what we see in Parkinson's disease. Here we don't have access to these scans routinely. They're done mostly for research, but I know some countries do have access to that. There are other more, research-oriented, but because of the very significant change in the substantia nigra, there's a lot of work being done looking at different aspects of the nigra to see whether you can be more precise. I think, sometimes when people think about Parkinson's disease, I think, well, how difficult could it be? This is a clinical diagnosis, but in early stages, we have a lot of trouble with some people, and, I always tell my residents, nobody walks in with a diagnosis, on their forehead. They telling you symptoms, and, later on, it is very easy to make diagnoses for the most part, not in everybody, but it's early on. I see patients with a lot of atypical Parkinson's, and they've, had, 3 years of the misdiagnosis of Parkinson's disease, and the patient's going, I don't look like the other Parkinson's patients. And so it isn't trivial for us to make these diagnoses. And so there's some people looking at neuromelanin. There's also this nigrosome that some people have, reported could be quite useful at looking at, at the nigrosome in the around the substantia nigra. And so, there's a lot of work being done. This is on susceptibility weighted imaging, looking at the barn swallow tail. I have to say, the initial reports showed that this was very useful for differentiating Parkinson's from atypical Parkinson's like PSP. We're not entirely convinced yet. So we have had some cases that have fooled us because they've gone to pathology and we can see that they don't have Parkinson's disease. So work in progress, just to show that, I think imaging is becoming more and more important for us in neurodegenerative diseases, as well as other biomarkers. Multiple system atrophy is again another of the alpha-synucleinopathies. This is a rarer disease characterized by autonomic failure, and as well as the Parkinsonism, like rigidity, tremor, postural instability. And of course, this is another illness that early on can look a lot like Parkinson's disease. And this is one where you would hopefully not misdiagnose as Parkinson's, because these people would progress rather rapidly compared to Parkinson's disease. And so, you want to be on the lookout and rule this out. There's 3 different types. They don't respond as well to the to levodopa, the classic symptomatic treatment of Parkinson's disease. On imaging, when the patients have it, they have really classic kind of imaging findings. There's the hot cross bun sign, which is a selective loss of the myelinated transverse pontocerebellar fibers. And so you can see this, the sign in the pons that looks like a hot cross bun. You see this putaminal slit. So this T2 hyperintensity in the putamen due to gliosis. So, these aren't always present and so are not used as diagnostic markers, but obviously if you see them, then it kind of helps give away the diagnosis. Huntington's disease, again, this is one of the neurodegenerative disease related to, it's an autosomal dominant genetic disease with expansion of repeats in the Huntington gene. This is not, again, diagnosis by imaging. This is, something we do by, we use genetics to make this diagnosis. But, if you see shrinkage of the caudate, it does, make us think of Huntington's disease. Frontotemporal lobar degeneration is actually a family of syndromes where imaging actually features quite prominently in the diagnosis. These are 6 syndromes with behavioral, language, or motor changes. They are associated with different types of pathologies. And here you will see amyloid and tau, because in some cases, actually, even Alzheimer's disease pathology can cause these syndromes. So the imaging alone is not enough to tell us anything about the underlying pathology, but it is helpful for making the diagnosis. The original family of syndromes was behavioral variant frontotemporal dementia, semantic variant primary progressive aphasia, and non-fluent aphasia. And I'll go through these. We now know there's 3 other syndromes that belong to this family. One is frontotemporal dementia with motor neuron disease, corticobasal syndrome, and progressive supranuclear palsy. And the reason that they've all come under the same umbrella is because, overlapping genetics, overlapping pathology. So behavioral variant frontotemporal dementia, well, as the name implies, change in personality. Cognition can be relatively preserved, and if it's altered, it's really an executive profile, so memories can be pretty good, although sometimes not. But there's early disinhibition, talking to strangers, acting inappropriately, early apathy, giving up hobbies, work, family. They can be non-empathetic, very sad or euphoric, but not related to any deep emotional ties with their families. They can have these aberrant motor behaviors, changes in diet, and on imaging, you really see the classic, frontal and anterior temporal lobe atrophy. Here you can just see the orbital frontal, but you can see here. There's to arrive, so if you have only the clinical symptoms, actually the diagnosis is possible behavioral variant FTD. So to get to a diagnosis of probable behavioral variant FTD, you have to have image supported, findings, or have a mutation. So obviously, if you have a genetic cause in C9 or granulin or MAPT or FUS, then you get a diagnosis of probable behavioral variant FTD. But otherwise, you need the image supported to get to the probable diagnostic criteria. And the underlying pathology, unfortunately, cannot be determined by the changes in imaging. We now know that frontotemporal dementia can be associated with motor neuron disease, and it's actually not that uncommon. So 14% of FTD patients had definite motor neuron disease. 52% of motor neuron disease patients met criteria for FTD syndrome. So it's actually quite common to have an overlap. Makes sense because there's overlapping genes, overlapping pathology. There are no classic diagnostic imaging features, but we do often see lots of excessive atrophy in patients who have associated motor neuron disease with FTD, but that's not diagnostic. The primary progressive aphasias are actually a family of syndromes. There's 3 of them. 2 are caused by frontotemporal lobar degeneration, and 1 of them by Alzheimer's disease. And in these conditions, you really want to hear only about language problems for the first 2 years. So memory is usually good, visual spatial function is good, executive function is good, but there's alterations in their language. The 3 different conditions are, the ones caused by frontotemporal lobar degeneration are the semantic variant and non-fluent variant, and the one by Alzheimer's disease is usually logopenic variant. So semantic variant is basically a disease where people cannot comprehend. They have impaired naming, even single word comprehension is impaired in these people. They also have what we call surface dyslexia. They can't read island properly. They'll read Iceland because they don't remember what the word is. They don't know what it means. They can repeat very well because their memory is completely intact, at least early on, and they can speak very fluently. In fact, they often will speak a lot, and the families will say they have increased output and they interrupt and talk a lot, but really it's the comprehension that's the problem. In terms of what we see anterior temporal lobe atrophy, which is obviously makes sense because of that's where our semantic hub, and that's how you get a image-supported semantic variant primary progressive diagnosis. So left anterior temporal lobe atrophy. Now, we do know that there is a right anterior temporal lobe version of this also, and it is very, and it presents with personality changes. But like I said, to get to a diagnosis of probable or image-supported semantic variant, you want to see this anterior temporal lobe atrophy. Of course, if you have the pathology, you obviously have definitive diagnosis. But while people are alive, to get to an image-supported semantic variant, you want to see this left anterior temporal lobe or right anterior temporal lobe. Non-fluent variant is the exact opposite. These people understand, but they cannot speak. They have effortful, halting speech, inconsistent speech. They make sound errors, distortions. Their comprehension for single words is okay, but if you give them a very complex sentence, they do have trouble, but their object knowledge is fine. And in them, you would see this left inferior frontal gyrus atrophy, so, close to Broca's area. And here you see it again, and that's how you get a diagnosis of image-supported, non-fluent, agrammatic primary progressive aphasia. And this, you could also see some hypometabolism on SPECT or PET, but it's really focal changes. Cortical basal syndrome is a disease, again, of, has motor aspects to it, alien limb, some bradykinesia, tremor, as well as some cognitive impairments. People used to think about cortical basal syndrome as having this asymmetrical atrophy, and that's when we, obviously think about it, but many cases do not have this asymmetrical atrophy, and in the pathological series, you can't really rely on this. But, if you see this frontal parietal asymmetrical atrophy, it helps make the diagnosis. We now know that a lot of times we get it wrong. and that there's various presentations, and to date, imaging hasn't helped us as much as we would like for this condition. Cortical basal syndrome is the actual clinical syndrome. The cortical basal degeneration is the pathology, and we know that it can present with, frontal presentations, language presentations, and of course the more classic cortical basal syndrome presentation. So, this is a disease that we're still struggling to find good imaging markers. Progressive supranuclear palsy used to be known as Steele-Richardson-Olszewski disease or Richardson's disease. This is a disease that includes falls early on, supranuclear ophthalmoplegia, so can't look up and down very well. They have Parkinsonism, axial rigidity more than limb, frontal dysexecutive syndrome, and a short lifespan. Classically, what we see is this midbrain atrophy, so this hummingbird sign, which is highly diagnostic of progressive supranuclear palsy. We can see this rounded midbrain peduncular here, and so there's a Mickey Mouse sign, morning glory sign, where you see the cavities of the internal margins of the midbrain tegmentum. There's these new indexes where people are measuring, the midbrain, the pons, and trying to find, and the actually superior and middle cerebellar peduncles, and trying to find these indexes to help differentiate. Like I said, it's not as trivial. Sometimes it seems like, well, how could you not know, right? But early on, patients don't have all the symptoms. And so early on, some of them look quite similar to Parkinson's disease. And so, I get a lot of patients with PSP who've been misdiagnosed with Parkinson's disease for a number of years. And then, by the time they get their diagnosis, they're more advanced. And, you can see their lifespan is not like a Parkinson's patient lifespan. And so it is important to make this diagnosis earlier on. We now know there's different variants. So in 2017, new criteria came out for PSP, and so that Richardson syndrome, that classic presentation, actually is only one of the presentations. So, there's PSP, which is just Parkinsonism, or just progressive gait freezing, or cortical basal syndrome. So, some of them are just language or frontal behavior. So it isn't so easy for us to make this diagnosis. And so we are really looking for better biomarkers to be able to diagnose people at earlier stages of disease. And, they have been clinical trials for PSP. And so it is important for us to think about that, if you want to put somebody in a clinical trial, you do not want to put them at late stages of disease. Vascular disease dementia I include in this, not because it's a neurodegenerative disease, but because it's very, very common. It's probably the second most common cause of dementia in the world. And, it's until recently, people used to make a diagnosis of vascular disease dementia if somebody had had a stroke, and then a few months later, they started to dement. But we all saw patients where, they never had a stroke, and their families would tell you there's no stroke, but they would have lots of these white matter hyperintensities that over time become confluent. This is usually thought to be indicative of small vessel disease. And, obviously, this is something that we, are concerned about, right? Because there's some hypotheses that this actually makes Alzheimer's disease worse. Of course, this can be co-pathology with any neurodegenerative disease. And this is a preventable disease. This is a modifiable disease. And so it is really important to, educate people about the impact of their lifestyle choices on their brain, because oftentimes people don't realize this. And so, I think more and more this is being recognized. Unfortunately, CT scans are not great for picking up the extent of the vascular disease. With MRI, people are using different scales. This is a very common one, the Fazekas scale, and really just to try to, again, harmonize standardize the reporting so that, clinicians speaking to patients could find it more helpful. Like we have a lot of primary care memory clinics here, and those physicians, many of them don't ever look at their MRIs. They actually read the reports very carefully and base a lot of their clinical decisions on them. So we do think that it's quite important to do this. And as I mentioned, mixed pathology is actually very, very common. And so although we do have people that we know have only vascular disease in the brain because we look for biomarkers, we also have people who only have Alzheimer's disease, but there's lots of people who have co-pathology. And we do think that this is impacting the progression of their disease as well as their symptoms. I'm not going to say that much about mild cognitive impairment, but you all realize that this is pre-dementia stage, right? For a long time before you have dementia, you have mild changes. Actually, nowadays we even think of subjective cognitive impairment. But with mild cognitive impairment, people have a concern about a change in their cognition. It's detectable, but they're independent in functional abilities and they are not demented. And we know that there is a spectrum of changes that occur in your brain before you are diagnosed, even with mild cognitive impairment. And the amyloid starts to build up in your brain, the tau builds up in your brain. These are detectable. And basically, this is a window of opportunity for us. Most of the data comes from Alzheimer's disease, but we now have evidence that this can happen in frontotemporal dementia, where even 20 to 30 years before genetic causes of FTD, we see changes in certain structures of the brain. We know that it can occur in Parkinson's disease also. And so we really are trying to move towards earlier diagnosis. When we see brains like this, we actually can say what, the cause is of these people's dementia, but we don't want to be waiting to this stage to make a diagnosis because as far as, we're concerned today, we're not bringing any brain cells back. I just like to include this because oftentimes in our reports, we see, age-appropriate atrophy. And, I think that's very difficult to really relay. There are some programs now to quantify this, but, with big databases, but, our brains are at maximum mass around 25, 30 years old, and there's gradual loss with each decade. And, people have actually quantified how much gray matter you should lose, how much white matter you should lose, how much your ventricles should increase. And so there is age-appropriate brain atrophy, but I have to say that many times what I get as a report of age-appropriate atrophy, I do not feel is age-appropriate. And obviously, I'm looking at it with the eyes of the clinician who's met the patient. I also see the opposite extreme, where there are patients who, are in their 80s and have no atrophy. So I think it's not so useful to use this, and we should move towards more precision, towards, our brain and reporting. It's also been shown that actually our brains don't have uniform atrophy related to aging. And so the frontal and parietal areas atrophy more than the temporal and occipital areas. So when we say age-appropriate atrophy, is it, just the frontal areas or all the areas? So, we really should be thinking about moving towards more precision on this. And, over 10 years ago, I guess, we had reported that, that the neurologists and geriatricians really should be more precise in the questions that we pose our neuroradiologists and radiology colleagues, because that actually helped the radiologists give more accurate diagnosis. At least this was true for behavioral variant FTD, which, I've shown you has a very specific pattern, and so is probably one of the more easily detected. Again, not early on, but at least in, the moderate stage of disease, there's quite significant atrophy there that, is easier to detect. And so should be reported as such. So in summary, neurodegenerative diseases, are a growing problem, and there's need for more accurate diagnosis. We are optimistic that we will be moving towards targeted therapies for these diseases, but really that can only be done if there's more diagnosis, more accurate diagnosis, and imaging will be a core feature of this. Even if it's not a pathological diagnostic, imaging will help people make a diagnosis. And really, I think accurate diagnosis is the first step in getting people targeted therapies and prognosticating. So thank you for listening, and if you have any questions.
Thank you so much, Dr. Tartaglia. That was a fantastic lecture. I just have one question for you. We have lots of patients who have alcohol and substance misuse down here with our demographic in Hastings and East Sussex. And do you find that there are certain patterns of atrophy that you see in those patients? Or B, do you find it makes your job more challenging allocating them to a specific disorder when there's overlap with substance misuse?
Yeah, no, that's a great question. And we actually have evidence that alcohol excessively shrinks the brain. So you will see excessive shrinkage of the brain, and it's quite generalized, right? This generalized atrophy. So it's very difficult. And sometimes when people stop drinking, you see that actually their cognition improves. And then, that's how you make the diagnosis that there's no degenerative disease. And we do see that, not that we have a huge population with this, but I have seen that even the brains get better. They look better. And so, when I see generalized atrophy, without a predilection of the hippocampi, there's not that classic signature, there's not a ton of vascular disease, although in some of these cases there are. Then I start to wonder, and then when you talk to the patient, you obviously get it, like they're in my clinic because they have a concern. They showed up for, and then we find out that alcohol could be a factor.
Thank you. Any other questions?
Can I ask a question? I'm an endocrinologist, and we often see there is an increased incidence of dementia in persons with diabetes. The question is, well, what is not very clear is diabetes causative, or is it just an association, or is there any specific radiological markers to say this is diabetes related?
Yeah, in the last few years, people have really, there's, been kind of this thinking of, is Alzheimer's disease type 3 diabetes, because there's a lot of overlap. So I think it's a great question, and it's still debatable right now. I think one thing, though, you do often see in diabetics, and that's why, I think it's very important to do MRIs in them, is you see that they have a lot of cerebrovascular disease. So you really need to look for that. And, you can sometimes get patients to be more adherent to their diets, to monitor their vascular risk factors more closely with that. But we also know that if you have more cerebrovascular disease, you are more prone to accumulate Alzheimer's disease, and it can make it worse. So there's probably a very significant component of diabetes in vascular disease as well as Alzheimer's disease. And, there's some treatments actually aimed at that right now, and there was an insulin trial actually in Alzheimer's disease. And the first one was positive, the second one was negative. So it's still an ongoing debate. Thank you.
Any other questions? Well, if that's the case, I'll just say again, thank you so much for your time and expertise. And we all appreciate you taking this time before the start of your working day to give us this lecture. Thanks a lot.
Thank you.
Have a great day.
You too. Bye-bye.
Bye-bye.